in stage 3 would be considered advanced, usually surgical. And there you have frequently pneumoperitoneum, where this is considered surgical, but many of these babies have drains placed and the surgeons never take a look. So this is problematic. Now, when we look at these Bell staging criteria, the stage 1, if you look at the textbooks, limited NPO, you rule out sepsis and give antibiotics, bowel decompression and close monitoring. Well, how long do we need to give antibiotics in these babies? We really don't know what the right course of antibiotics is. Most of these babies just simply have some problems with dysmotility, which is transient, and they have feeding intolerance. Stage 2, if we see something that is definite, what we usually do is give them NPO, make them NPO, and start them at IV antibiotics for 7 to 10 days, and we notify surgery. Well, we don't have a good idea of how long these babies actually need to be on antibiotics or NPO. This is problematic, and sometimes we treat them way too long, much longer than they need to be. And stage 3 is a surgical decision. So here we have a baby who had an incidental radiograph done. And this was done for a reason other than abdominal problems. And the radiologist looked at this and said, here in the right upper lobe, I see this bubbly appearance that I think might be pneumatosis intestinalis. Well, when we see this as neonatologists on the X-ray report, what do? We generally will take these babies and place them NPO for 7 to 10 days, start antibiotics for 7 to 10 days, and these babies are probably overtreated in many cases, as I mentioned. This baby had the X-ray repeated a few hours later, had a totally benign abdominal examination, CRP and platelet count, white blood cell count was normal. This was gone after those couple of hours, and this was probably just stool within the bowel lumen, or something, sometimes that I affectionately call pupitosis, not pneumatosis. Here we have a couple X-rays that are clearly abnormal, but we don't see portal venous gas. We don't see pneumatosis. These are the kinds of X-rays that Yasser can do magic with his ultrasound, and probably give us a much better idea of what is going on in the abdominal cavity in these kids. So I think that ultrasound will be very useful, is very useful in certain people's hands, but I think that we need to have generalized much better experience with ultrasound to be able to use it effectively in general. But this can be a diagnostic dilemma using these techniques. So we want to be able to prevent these forms of bowel injury that we are calling necrotizing enterocolitis. And one of the things we do very commonly is we are very conservative, and we keep these babies NPO for long periods of time. And we really don't know how to advance them in the most optimal composition. We have major concerns about hypoxia ischemia, but we are finding that hypoxia ischemia, for the most part, is not a major antecedent for the development of necrotizing enterocolitis. We think that antibiotics may be related to necrotizing enterocolitis, but not necessarily for the prevention, but rather they are their use may actually be related to the development of necrotizing enterocolitis. So here are some other areas of interest that we can discuss, but my time is short. Do we have good biomarkers for necrotizing enterocolitis? Well, some of the most commonly used tests beyond abdominal radiographs performed when the diagnosis of NEC is suspected include the white blood cell count. It can be either elevated, highly elevated, or it can be very low. Electrolytes are sometimes used, and one of the commonly used electrolytes is hyponatremia, the sodium level becomes low. Inflammatory markers such as C-reactive protein are used, but all of these have poor sensitivity, specificity, and positive predictive value for the diagnosis of necrotizing enterocolitis. Better biomarkers are clearly needed. Here are a few other biomarkers that have been studied. Intestinal fatty acid binding protein is a molecule that is released by damaged epithelial cells. Claudin 3 is a protein that is found in the tight junctions of epithelial cells. And when the tight junctions break down, the Claudin 3 gets into the bloodstream, and it's water soluble, just as is intestinal fatty acid binding protein, and can be found in the blood and also in the urine. Calprotectin comes from white blood cells and inflammation, and calprotectin is usually found in the stool. Well, studies have been done on these, but these studies have been done at the beginning of symptoms. That's when these samples were collected, and that's problematic. But all of these 3 tests have shown very high sensitivity and specificity and likelihood ratios and also accuracy. But again, they're problematic from the standpoint that they were not looked at from the very beginning, shortly after these babies were born, and looked at systematically prior to the development of disease. That needs to be done. And the problem with that is that necrotizing enterocolitis, in order to do a study like this, you need a very, very large sample size to be able to do it with enough predictive power to be able to do this kind of a study. This is a recent article, and I just want to refer you to the title. Early postnatal comprehensive biomarkers cannot identify extremely preterm infants at risk for developing necrotizing enterocolitis. And this article very nicely goes through a lot of the biomarkers that have been studied. Now, what about antibiotics? I mentioned that antibiotics can be problematic with necrotizing enterocolitis. And one of the things that antibiotics do, if you use them early and if you use them too much, is that you can take a balanced microbial community, and with antibiotics, you lose a lot of the commensal, potentially protective microorganisms. And that sets the gut up for increased toll-like receptor signaling, increased immune dysregulation, which can be problematic and lead to intestinal inflammation. Studies have been done looking at the microbiome of the intestinal tract prior to the development of necrotizing enterocolitis. And this is a study that I did with Professor Mohan Pami from Baylor. What we were able to do was take data from 8 different neonatal intensive care units where they looked at the microbiome prior to the development of necrotizing enterocolitis using 16S sequencing techniques. And these were from the sequence data from these 8 different neonatal intensive care units. On the left here, we see control babies over time, and these colors represent different phyla of bacteria. And here what we see in the babies who develop necrotizing enterocolitis is over a time, we see this increase in the blue and the decrease in the green. And we see very few of this bright yellow phylum of bacteria in the NEC babies. And here we see histograms here of the proteobacteria, the firmicutes, and the bacteroidetes. Proteobacteria are largely your gram-negative bacteria that have a lot of lipopolysaccharide in their cell walls. And when there's a lot of lipopolysaccharide, that stimulates the toll-like receptor 4 to cause an inflammatory response. The firmicutes are lower in the NEC babies, and these are thought to be the good bacteria. And these good bacteria produce a lot of short-chain fatty acids, such as lactate, propionate, and butyrate. Butyrate is the most important fuel for colonocytes. Butyrate also maintains the integrity of intestinal epithelial tight junctions. So if you lose that, as we see is happening prior to NEC, you have an opening of the tight junctions. And what that will do is allow microbes and material to get through the tight junctions of the epithelial cells and cause an inflammatory response. The bacteroidetes were also lower in the NEC babies, and these bacteroidetes cause a signaling in dendritic cells to produce more anti-inflammatory mediators, and that is lower in necrotizing enterocolitis. So we see the types of microbes that actually can be problematic, that appear to be associated with more necrotizing enterocolitis. Well, if we look at the use of antibiotics, here is one of 3 studies that show that the odds ratio of necrotizing enterocolitis increases with the days on antibiotics. So the average length of treatment, if it's between 5 to 8 days, increases the odds ratio of the development of necrotizing enterocolitis by 50%. And here we see what happens when we don't feed babies, when we give them total parenteral nutrition for a long period of time. These colors represent different phyla of bacteria. And here in the TPN babies, we see a lot of this dark blue. Okay, what is the dark blue? The firmicutes, and in the controls, we see less of this dark blue. In the controls, we see very little red, which is the bacteroidetes. I'm sorry, yes, the bacteroidetes. But here we see even less in the TPN babies. In the TPN babies, we see a lot of the green, and these are the bacteroidetes. In the control, we see, I'm sorry, the proteobacteria, and here in the controls, we see very few of these relatively fewer of these proteobacteria. And remember, these are the guys that cause inflammation. So more TPN, more inflammatory bacteria in the gastrointestinal tract. Okay, and I just want to mention very quickly something about probiotics, because that always comes up with as a question, and where are we now with the use of probiotics? In the United States, there's only about 15% of the neonatal intensive care units are using probiotics routinely, and that's probably too many. Why? Well, here we have the meta-analysis by Dr. Deshpande done in 2010, where they looked at 11 different studies where 10 different probiotic preparations were used. And in that study, probiotics favored, or these meta-analyses favored probiotic use. But remember, 10 different probiotics were studied in this meta-analysis. Now, when we think about this, we have over 200 probiotics available to us. The question I have for you is, which probiotic do we use? If you have a child with an ear infection, do you use any antibiotic? Would you use chloramphenicol for an ear infection? Well, we need to know which probiotic would be the most helpful. The largest study so far that has been done that actually was done correctly, and there's only one that has been done correctly as a double-blinded randomized prospective study, was the one done in the UK, where they looked at Bifidobacterium breve probiotic, and they powered this for NEC as the primary outcome using 1,315 babies, and they found no difference in NEC, late onset sepsis, or death. Here is the latest American Academy of Pediatrics recommendation for the use of probiotics. And here, what they say is that given the lack of FDA-regulated pharmaceutical-grade products in the United States, conflicting data on safety and efficacy and potential for harm in highly vulnerable population, current evidence does not support the routine universal administration of probiotics in preterm infants, particularly those with a birth weight of less than 1,000 grams. And I just want to remind you that human milk contains microbes. Human milk also contains many factors that are potentially helpful, such as immunoglobulins and white blood cells. And so providing the baby's own mother's milk can be very helpful for the prevention of necrotizing enterocolitis. So I'd like to summarize. And here, number one is not all neonatal intestinal injuries should be called necrotizing enterocolitis. We need better definitions and delineation of the pathophysiology of these distinct intestinal injuries. We need to aim toward prevention and not treatment. The intestinal microbial environment, along with developmental aspects of the gastrointestinal tract, are critical elements in the pathogenesis of some of these intestinal injuries, but not all. Once we have a clear understanding of the different causes of different forms of these intestinal injuries, we will best be able to target preventative strategies. Thank you for your attention.
Dr. Adeli, are you there?
Yes.
Yes, Dr. Sama. Thank you so much, Dr. Joseph, for this informative presentation. Any questions?
Yes, I have one, please. Yes, I have one, Dr. Afaf Tura. Thank you, Doctor, for this nice presentation. But I think that there is still a debate about the probiotic, because WHO at I think their guidelines 2017 they recommend the probiotic. This is number one. And number and I'm with you that there is no specific type of probiotic. And also I would like to ask about the lactoferrin. As they said that lactoferrin with probiotic, it's okay because probiotic will activate the lactoferrin or vice versa, but lactoferrin alone is not effective. So I just want to know what's your opinion about lactoferrin and the other recommendation and other guidelines.
Yeah. So yeah, very, very good question. And I think that this is a very important point that you make. Number one is the WHO recommendation is not based on premature babies in the prevention of necrotizing enterocolitis. That is it's a different form of recommendation that is looking at largely developing countries' prevention of sepsis, and it is not focused on necrotizing enterocolitis in the preterm infant. Okay. The other point you make about the lactoferrin, I think, is also very interesting. And there have been studies looking at lactoferrin, but if you really look at those studies carefully, were they done adequately powered prospectively to look at necrotizing enterocolitis? You need to have a prospective study that involves around 1,300 babies to be able to have adequate power to evaluate necrotizing enterocolitis. And even that is highly problematic because what I talked about with the definition of necrotizing enterocolitis and how we actually define necrotizing enterocolitis in such a study. So I think that that there may be some role for necrotizing enterocolitis for lactoferrin in some form of gut injury, and we need to first get a better feel for these forms of gut injury before we can really look at some of these interventional preventative therapies.
Okay, thank you. Thank you.
You're welcome.
Thank you so much, Dr. Joseph.
I have a question.
Yes.
Thank you very much for this presentation. I agree with you that not all cases of intestinal injuries are NEC, but actually you will left us with dilemma, because when a preterm baby or even full-term baby got the symptoms and signs of suspected NEC, so what will be the diagnosis? You didn't mention anything about measurement of superior mesenteric artery blood flow, which can help in discriminating these cases. Also, there are some markers. You mentioned some markers that measure cases with NEC, but there are other studies with other markers that can predict necrotizing enterocolitis. It's something like the inter-alpha inhibitors, like the ischemia modified albumin. We just recently published article about ischemia modified albumin in predicting and diagnosis of cases of necrotizing enterocolitis. So these markers, it can discriminate suspected NEC from cases with truly NEC in patients with symptoms like abdominal distension or feeding intolerance.
Yeah, and I think that you know, all of these biomarkers, if you look at them very closely, so for example, you mentioned the blood flow studies. What kind of NEC are we talking about when you do the blood flow studies? You have necrosis of the intestine in babies with hypoplastic left ventricle or interrupted aortic arch. That is going to cause a decrease in mesenteric blood flow. But that's not the same necrotizing enterocolitis that we see in many of our preterm babies. All of these different markers that you talked about have not been studied systematically in large groups of babies to really show whether they predict necrotizing enterocolitis or not. And as I said, with the Claudin-3 and the IFAB, most of these studies have utilized the first symptoms of the babies, and that's when these biomarkers were done, rather than starting at the very beginning and looking at these before the symptoms actually developed, and then looking back at these to say that this is a true predictive biomarker. And that's one of the other things, is we need to be able to separate a predictive from a diagnostic biomarker. And there is a difference between the two. So you may be talking more along the lines of diagnostic biomarker, but the diagnostic biomarkers may be somewhat helpful, but I think that the predictive are the ones that are going to be the most valuable, that will help us prevent these forms of gut injury that we are calling NEC. Does that help answer the question?
Any more questions?
I have one question.
Yes, please.
Thank you, Professor Neu, for this nice lecture. And I want to ask about the duration of NEPO. If we diagnose a patient with NEC, يعني stage 2, I know we don't say stages now anymore, but if he was diagnosed with clinical abdominal signs, systematic signs, and sonar showing decreased motility and decreased mesenteric blood flow, we have to stop feeding for 10 days, even if the symptoms are reversed in much less time than that. And sometimes the patient is clinically well and he's passing stools, but still the sonar shows that there is still decreased motility, or there's still evidence of NEC. So which is better, to go with the sonar till complete improvement with the sonar, or go with the clinical findings, especially if the patient is passing stools?
Yeah, so that's a really good question. And let me just posit one thing, and that is that if you don't feed, you're going to have less motility.
Yes.
Okay, so putting food into the gastrointestinal tract stimulates motility. So you may want to start very slowly a little bit earlier in some of these babies and see if you are getting increased motility. You know, if you have very good ultrasonography in your unit, that may be one way to look at it, is start with very slow feedings and seeing if you can actually get increased motility. And I would guess that most of those babies would respond in a positive manner by feeding and by watching their motility. What I do is I rarely keep a baby NPO for 10 days. That is what I consider to be dogma and not based on science. People were very careful because they were just concerned that these babies would develop, that this would exacerbate their symptoms if you don't treat them for 10 days. So they picked a number that was very conservative, but many of these babies could do quite well with just a few days of NPO.
Okay.
I think Yasser may actually have something to say on that, because he's actually been using ultrasound to help with in that situation.
Yeah, thank you, Joe, for referring the question to me. So I would like to emphasize on a very important point. In ultrasound, we have about 11 markers, and we should not rely on only one marker of them. So motility is one of them, and as Joe said, that motility will be induced with feeding. If you're keeping longer time with NPO, you will be inducing villus atrophy. You will be inducing actually more motility-related issues. You need to start some feeding to induce motility. So in ultrasound, we have 11 markers. Relying on mesenteric blood flow is not very reliable unless you have decreased or stealing blood through the global blood flow through the intestine, like if you have PDA or congenital heart disease. So typically in mesenteric blood flow, you're just looking at the systolic and the diastolic flow and maybe assess the resistive index. That might be helpful in some situations, but in NEC, you may have significant ischemia or you may have hyperemia. And
in the early stages, yes.
So in ultrasound, you need to look at the intestinal wall signature, the layered intestinal wall. You need to look at the dilated loops. You need to look at the perfusion by color Doppler, the speckled perfusion. You need to look at the signs of ischemia. Motility is one of them, and motility in premature infants is very slow. You need to look at one very long loop for maybe up to 1 minute to allow it decrease motility, and you need to look at all of the abdominal quadrants, the 4 quadrants thoroughly, and with an expert person to exactly evaluate motility. So motility by itself as a single parameter is not very reliable unless you have at least 2, more than 2 markers in more than 1 quadrant to rely on. Ischemia or global hyperemia, absent motility all over, not isolated. Nematodes intestinalis, portal venous gas usually disappear within 2 to 3 days. They are not very reliable for follow-up. Portal venous gas, usually you will see it on the first day. While ultrasound is very sensitive, you can pick up even very mild occasional portal venous gas, but within hours or second day, everything disappears. So the duration is global assessment with ultrasound, clinical assessment, or other marker like CRP, if you have the ability to do serial CRP with the titer. Clinical assessment, soft lax abdomen, infant is clinically stable. That's even more important than ultrasound. Ultrasound is helpful to add on. We have started feeding for infants with mild NEC 3 to 5 days.
This is my question. I can start feeding at around 5 days. I don't have to stay for 7 days clinically improved.
Yeah, very good. Yeah, if you have someone who's able to assess gut performance accurately, clinical assessment is very important. Decreasing